Hello?
Hi. Hello, everyone. Good morning.
Right.
So, despite the COVID pandemic, we have our everyone is still in high spirits, and it's very good that we have this session will now start with our
Hi.
new president. Hello. Hello.
Yes, go ahead.
Yes. Okay. So for today, we have for the session of bariatric and metabolic and pandemic, we have two speakers. I'll first introduce our first speaker. Then after this, we will proceed with our second speaker. Thereafter, we will have our question and open forum. To begin our presentation, our first speaker is the president of the endoscopic is the current president of the endoscopic and laparoscopic surgeons of Asia, and also the laparoscopic endoscopic surgeons of Thailand. He was the Congress president of the 14th ELSA convention in Chiang Mai last year, and currently a governor also of the ELSA, as well as the president elect of the Asia Pacific Metabolic and Bariatric Surgery Society. He is also the Secretary General of Mekong Endoscopic Surgery Development Association and an executive committee member and a foreign affairs chair of the Royal College of Surgeons of Thailand. He is also holds an honorary membership of Philippine Association of Laparoscopic and Endoscopic Surgeons, as well as the Japanese Society of Endoscopic Surgery. I'd like to introduce our first speaker, Dr. Suthep Udem Suing Sup. Dr. Suthep, Professor.
Thank you. Thank you, Paulo. Thank you very much. Thank you, PALES. Congratulations to Mr. President, Professor Mendoza. And also congratulations to all the PALES ex-committee. I have attended and enjoyed the morning session very much. You all make me like I am sitting over there and enjoy the morning session. So thank you very much. And also congratulations. So as we know that right now we are in the era of COVID-19, even some countries may have a bit tough. Some countries may have been getting some control, but anyway, it's still with us without any vaccine. So I think this is what we have to learn from each other and what we have to do. So let me share a little bit about our experience in Thailand before getting into the bariatric and metabolic surgery. So this is Thailand. You can see that similarly to Philippines, our mainly of our economy is coming from our tourists. For last year, we have almost 40 million tourists visiting us. And if you have a look, it's about 1/4 of them are Chinese people. So that without no doubt, when it was first started in China, we've been very much carefully observing, and unfortunately, first case was reported on January 12th. There was a Chinese tourist visiting us, and you can see that for the first 14 cases will be imported case from China only. Eventually, we have our own local infection from the January. With that, you will see that 19 cases in January. After that, you may expect to see the curve would be increasing, especially early March. So what we have to respond, especially for bariatric and metabolic services, our center, Chula BMI, the Chula Bariatric and Metabolic Institute, we suspend our services, both the outpatient and also inpatient, because we learned from Chinese that one of the very major risks for the patient who got infected would be obese with several diseases. So that's why we take responsibility to serve and also to save our patient by suspending our services. And we turn all activity to be online platform. And the activity from the government, you will see that we declare the state of emergency over all the area in the Kingdom of Thailand since March 26. If we are not doing anything or we do it less than it should be, it would be 50,000 cases in early April. So that the government itself has been collecting all expert, and the decision was to fatten and also to contain the number of cases. So several activity has been doing. You can see that the state of emergency has been declared, then also following by the curfew from 10 p.m. to 4 a.m. was applied on April 2nd. So it limited that, and everyone advised to be working at home, even our colleague in medical field. And everyone advised to wearing masks, washing hands. This is medical student. We're still having to do the distancing. So I think one of the very much important measure to control the spread of the virus would be self-protection. Especially you see that wearing masks, hand washing has been very much followed by the patient, from the population, from Thai people. So that's why making the number to be fattened. And activity will be online, as mentioned earlier, the services and also academic activities. This is what it was last 2 months. So everything needs to be in the distance, even in the escalator. I think every place has been doing the same. So that you will see the curve when it was first infected in Thailand, it called alert phase. We're still having normal OR schedule, but during the acceleration of the number of cases, for sure, we suspend the services. You will see that the OR theater needs to be reduced to 50%. We have to reserve our resource for those in need and also to prepare for the pandemic. So if you reduce your services to 50%, for sure, bariatric metabolic surgery must be suspended. So we reserve only for emergency and urgency and also cancer. I think all would be accepted that we should do that. And the question at that time during April and May is that when we can do start our elective cases. So with that, we monitor. This is in our hospital, King Chulalongkorn Memorial Hospital, which is one of the major center for taking care of COVID-19. They you will see the number of cases represented in the black color, and the active cases will be represented in the red color. So we have to monitor. You will see that during early May, our active cases in the hospital at reducing. The maximum number that we have is about 60 cases admission. So that when we have a reserve more than 50%, we've been discussing that we should do, we should extend our services, especially in the surgical services, to be an elective cases. So that's why we increase our ability to 75%, means that we've been reserved about 25% for the pandemic. And for those elective cases, we need to prioritize the patient who will be in need, functional transplantation, and also bariatric cases. So we divide every phase into 2 weeks. With that 2 weeks, the bariatric surgery would be serving for those who are very much in need and cannot wait. And then we follow. You will see that we're in a lockdown, and started from May 3rd, that the first case or first phase of easing of the lockdown has been started. With that part, we think with all information, data that we do have, we start our elective cases. And same like PALES, less the laparoscopic endoscopic surgeons of Thailand doing several webinars to gain our experience, sharing knowledge, as well as the webinar from ELSA that we've been doing early April. This is what we are doing for the Thai Metabolic and Bariatric Surgical Society. We also trying to earn our knowledge and also the try to get the information to the policymaker, try to inform that right now it should be ready to carefully start the bariatric surgery. So then you can see from our experience, started from mid of May, we've been backing into our normal, I should say that almost normal services with a very careful observing and monitoring the number of cases for the COVID-19. In early phase, for the first 2 phases, we have all our patients undergo the COVID-19 tests, the PCR tests, less than 48 hours before the procedure. And we observe in our hospital of those more than 3,000 cases. I mean, for all surgical services, we found 0%. None of them got the positive tests. So since then, we stopped doing mandatory tests for the pre-op. Means that right now we are doing our normal services without the pre-op tests. So let's share a little bit what we have done. I think you all know, and just to review that the COVID-19, the size will be about 0.06 micrometer. So with that, and also from the information, you will see that it's been shown that the SARS-CoV RNA has been detected in feces. That would be reminding us that when we are doing any kind of operation, especially with the bowel, you have to be careful. So, and also the government has guideline to trying to help us, especially the society has been giving the information to the government. And with this, you will see that theoretically doing laparoscopy would be better in terms of controlling the contamination in the theater. But anyway, we also accepted that both open and laparoscopy would be suitable during the COVID-19 era, but need to be very careful. So we follow ELSA and say yes, and EAS guideline you have seen already that we should do several things, how to do to make it safe. Yes, we follow that. We should do low CO2 pressure, just enough to do the operation safely. Must be making sure that we have adequate muscle relaxation. And the power need to be setting to very low, and ultrasonic has been alert that it might contribute a lot of the contamination anyway. So and gas leaks is also very important. How to do that? We make an incision small enough to accommodate the port to be in and make sure that we are not contaminated. This is also gas leak. How to do it? It's very important to protect the personnel in the theater. Try to get them in the theater very limited number, so that we have learned from our experience since we start our services again. And importantly, we have to be control the gas that would be releasing from the abdomen. So you see that any laparoscopy, we would do the evacuator joining to the port. So you can choose several available evacuators. So this one, for example, and all these for you to review if you choose. The thing is that the filter must be the alpha filter. You see from this slide that most of them will be alpha. So those will be hooking to the port, and the gas from the abdomen will be arranged and managed properly. So this is the norm that we are doing now in any laparoscopy. If you don't have those equipment, especially early in our experience that we start doing, and then it's not enough the machine to be hooking up, you can do the simple filter like this. So I think this also would be making sure, would assure that you would be take a low risk in the theater. So for all this, my conclusion, you will see that this is a curve for the daily cases in Thailand. So our worst part would be March and April. You see that the maximum cases per day, new cases per day, would be almost 200 cases in the late March, and then we'll be in with several measure that the government and the people, Thai people has together making to flatten the curve, and early May we can limit the number to be less than 10, and started from 26th of May we have no local cases. Those who will be positive after that will be the people who are coming back from abroad. Those will be mandatorily to be 14 days in the state quarantine. So right now about 60 days of no local cases. So that's right now, but we still under the very highly alert that it might happen again for the second wave, but hopefully will not be that worse, or it shouldn't be come early. So ladies and gentlemen, my colleague in PALES, what I would like to conclude is that the pandemic is still a challenging and stable situation that we are facing anywhere in the world, and bariatric and metabolic it's supposed to be suspended during the pandemic or the very highly infected period. After restarting your service, it should be under the surveillance. With the information from the surveillance, if you don't have the number of infection from those tests, I think we may not need to do the surveillance. But anyway, right now we categorize those candidates who are coming to the hospital for the operation. If they have any high risk as the PUI, of those will be under the test. If not, we will step forward with the our new normal in the theater. So thank you very much, and you all make me like you. I were already in Manila with you. Thank you very much.
Thank you very much, Professor Sotep. Very impressive with what Thailand has been doing with how they respond, how you guys have responded to the COVID pandemic. I understand that you mentioned that you were still doing operations even at 50% during the pandemic. We have some questions later, but because of the interest of time, we'd like to proceed first next with our second speaker. Our second speaker is currently the head of the Bariatric and Metabolic Surgery Center of St. Luke's Medical Center, also the chief section of weight reduction surgery at the Institute of Surgery in the same similar center. Previously, the past training officer of the MIS fellowship program in St. Luke's, a trainer of basic laparoscopic surgery in the Philippine Association of Laparoscopic and Endoscopic Surgeons. And he is also the president of the Philippine Society for Metabolic and Bariatric Surgery. Our next speaker will be presenting our uh, uh, a video presentation on the Sleeve Plus. Dr. Edward Oliveros.
Hi, good morning.
Good morning, sir.
Thank you very much, Sutep, for the wonderful presentation. Um, I'll, Let me just load my slides. All right. Sutep, thank you so much for coming and joining our virtual Congress this year. We're very honored. I'd like to thank the PALES organizing committee, specifically Dr. Jeffrey Domino, for asking the PSMBS to have a session in their virtual Congress. Thank you also for giving us this chance to present on the Sleeve Plus. I also like to thank Dr. Paolo Perjugula for helping me with my slides. So let's begin. So I'll be talking on the Sleeve Plus, updates on the sleeve gastrectomy. All right, I'd like to begin first with the evolution of bariatric and metabolic surgery in the world. These are the bypass and the restriction and a combination of both starting from the early 50s. It started with the jejunal-ileal bypass and progressed to varieties such as ileal bypass, jejunocolic, loop gastric, biliointestinal. That was in the early 50s. In the early 70s, the Roux-en-Y gastric bypass came out, followed by the BPD. In the 70s, there was the Nissen fundoplication, which progressed to vertical banded gastroplasty, gastric banding with wrapping, gastric plication in the 80s. In the late 80s to 90s, we had the gastric banding adjustable. Then this progressed to the following. Wait, hold on. These other procedures until you ended up with the sleeve gastrectomy in the early 2000s, late 2000s. These are my references for this topic today. I'll proceed to the outcomes of bariatric and metabolic surgery. We'll discuss this part in terms of excess weight loss, resolution of hypertension, and type 2 diabetes. So with the adjustable gastric band at 3 to 5 years, you can see the excess weight loss is around 52.5%. The resolution of hypertension is around 43%, and the resolution of type 2 diabetes around 47.9%. For the sleeve gastrectomy at 3 to 5 years, the excess weight loss is around 55%, slightly better. The resolution of hypertension is 66%, and the resolution of type 2 diabetes around 47%. For the gastric bypass, it's a big change. Excess weight loss is around 67.5%, more than 60% resolution hypertension, 83.7% resolution of type 2 diabetes. So it's well different from the other two. But for the most, with the best results, is the BPDDS. Excess weight loss of 3 to 5 years around 75%, and the resolution of type 2 diabetes and hypertension is way over the other three surgeries. For the worldwide trends of bariatric and metabolic surgery in terms of percentage, I just want to show you a chart from 2003 to 2013. In 2003, the most common surgery was the gastric bypass, followed by the gastric band. It was in 2008 when the gastric band started going down. And in 2011, the sleeve gastrectomy started to peak all the way to 2013 when it already outnumbered the gastric bypass. In terms of the primary surgery, the Roux-en-Y gastric bypass is most commonly done in South America, followed by Europe, and thirdly by North America. For the mini gastric bypass, it's most common in Asia Pacific, especially India. But for the sleeve gastrectomy, it's most common in the Middle East. That's unusual, but they claim so many cases, followed by North America. Now, the sleeve gastrectomy, for those who are doing this surgery, it does have controversies. One, it can be the technique. Everybody has their own technique. Primary outcome, their weight loss and metabolic effects are slightly different. Complications, especially leak and reflux, are different for different centers. The weight regain and the revision necessity. These are all controversies which every country has different outcomes. Just to show you one study, a very good study published in 2017 by Dr. Noel and Michel Gagne. In short, 23 out of 116 had revision surgery, 31% had GERD. At 8 years post-op, 59% was effective. So this comes to the question, is the sleeve enough? And I will answer this question because there are different procedures that have been added to the sleeve already, and we call it the sleeve plus. So these are the BPD with DS, single anastomosis duodenal ileal bypass with sleeve, the duodenal jejunal bypass with sleeve, ileal interposition with sleeve, sleeve gastrectomy with bipartition, and sleeve gastrectomy with proximal jejunal bypass. As you can see, there are 6 varieties already. There are more, but they're not documented yet. We'll go and talk about them one by one. For the biliopancreatic diversion with duodenal switch, what you have here is a sleeve gastrectomy, and the first portion of the duodenum is cut, and the ileum is connected to it, and the BPD limb brought somewhere near the ileocecal valve. Now, this is a very meticulous surgery. It has a high learning curve. Lifelong follow-up is a must. But excess weight loss in up to 5 years is 90%, very good. The rate of diabetes remission is better than the bypass at 82% versus 64% to the bypass. Although the protein calorie malnutrition in the first year is around 3 to 5%, so that's significant. For the next surgery, which is the single anastomosis duodenal ileal bypass with sleeve, what you have here is the sleeve. The first portion of the duodenum is cut, and the portion of the distal ileum is connected to the sleeve. So this one's a pretty good surgery also. Excess weight loss of 95% at 3 years, 63% at 5 years, but the diabetes remission is around 88%. It's very good. Some surgeons, especially in the high volume centers, this is what the surgery they prefer for a revision after a sleeve gastrectomy. Next, sleeve plus will be the sleeve gastrectomy with the duodenal bypass, or the DJB. There are 2 versions. Dr. Kasama of Japan pioneered the Roux-en-Y version, and Dr. C.K. Wang of Taiwan pioneered the loop version. So in this surgery, what you have is a sleeve gastrectomy, and a portion of the first portion of the duodenum is cut, and the jejunum is brought up to the sleeve gastrectomy, either as a Roux-en-Y or as a loop with 1 anastomosis. This is also technically demanding, has a moderate learning curve. The results are, as compared to the Roux-en-Y, the diabetes remission is 86% and 62% for the Roux-en-Y, so it's quite better. For the next kind of sleeve plus is the ileal interposition sleeve gastrectomy. This is quite complicated. What you have here are, it was called the diabetes surgery in 2003. What you have here are 2 kinds. The jejunal ileal interposition with sleeve, wherein there's no bowel exclusion. The ileal segment is interposed in the proximal ileum at 20 to 50 centimeters from the ligament of Treitz. For the duodenal ileal interposition, the ileal segments interposed between the divided portion of the duodenum and the distal end with the duodenum 50 centimeters from the duodenal jejunal flexure. Here you have a bypass of the duodenum and proximal jejunum at 50 centimeters. There is a complete and partial diabetes remission rates are around up to 80% in 2 years. Another complicated surgery, which is a sleeve gastrectomy with bipartition. This was first described by Santoro with the transit bipartition, and it was modified into a loop bipartition by Dr. Moy. It's also known as the SAESI, single anastomosis sleeve inter ileal bypass by MADI. So you have a sleeve gastrectomy, and the ileum is partitioned to the sleeve gastrectomy. Excess BMI at 1 year is 91%, very good. At 5 years, it's around 74%, but the diabetes remission is 86%. So pretty good. Here is something we all know in the Philippines, sleeve gastrectomy, proximal jejunal bypass. Dr. CK Wang was able to do the proximal bypass for the first time here in the Philippines around 3 years ago. So it was first developed in 2004 by Alamo and modified later on. Here, the jejunum is divided 20 centimeters from the ligament of Treitz, and a 250 to 300 centimeter jejunum is anastomosed to the proximal BPJ part. Excess weight loss for BMI of 35 patients and less is around 31.9% in the first month. In the 1 year, it's around 81%, and in 18 months, it's around 76%. So it's pretty good also. The complete type 2 diabetes remission at 18 months is around 81%. Well, my take on the sleeve gastrectomy, if it's done alone, it's very good initially, but later it might require revision because of weight regain and recurrence of diabetes. This could be around 3 to 5 years later. So that's why other surgeons around the world are adding additional procedures to the sleeve at the same time. It shows better results in terms of weight loss and diabetes remission. The sleeve plus procedures, in my opinion, should have a low learning curve, something similar to the sleeve gastrectomy, so that all surgeons, whether young or old, can adapt to this surgery. And of course, it must have less complications than gastric bypass. That's the most important, because it's always being compared to the gastric bypass. And we all know the gastric bypass does have complications in short term and long term. The sleeve gastrectomy should have less in order for it to be the standard surgery in the future. Well, that's the end of my lecture. And I always tell everybody nowadays, don't forget to take care of yourself first. Although patients are more important, but you yourself is more important. If the surgeon is not there, nobody can take care of the patients. Thank you so much.
Thank you very much, Dr. Oliveros. We had really good presentations, especially from our two speakers, Professor Sutep and Dr. Oliveros. Very impressive with your use of the keynote, Dr. Sutep. We have, I think, some time for questions, maybe around 2 questions in this session of ours. Anyway, I'm very curious, Professor Sutep, on how was everything laid out by your surgical society with regards to the laparoscopic surgeries, not including the bariatric surgery, with regards to how you made the progression from going 50% to 75%. Is this an inter-hospital deliberation, or is this a society management in terms of that the Thailand Laparoscopic Society?
Thank you, Paulo, for the question, and also thanks, Edward, for a nice presentation. Indeed, my presentation has been, learning from you, Paulo. Thank you for your, teaching for the presentation. Anyway, regarding the how we deal with the situation in Thailand, we have the committee to taking care of the situation. We say that for the government level and also in subgroup of any levels, for the surgical society, started from the Royal College of Surgeons of Thailand, has been giving out the guideline for the response to the pandemic and also the society. For example, Laplace, we ended up speak Society of Thailand also brainstorming the response to the pandemic, especially when to start with those our knowledges. We together, the committee and also the government, try to put together the information according to the situation that we've been monitoring. So all those information will be putting together. Yes, for sure. And during that period, it would be a challenging period that some expert would be trying to wait, but we together, we getting the information together, and then we start with a small, for example, started in our hospital, and then what with those information is been sharing, and then more hospital will be joining. So for the response, depending specifically to the hospital that you are belonging to, with the guideline, like the overview from the society and also from the government. So those information has been collaborated together and making the guideline.
Okay, thank you very much, sir. So it looks like the data that has been collected has been discussed and collaborated and thoroughly by each of the aspects, ranging from the medical side even to the administrative side of everybody there in Thailand. Something that we would probably be happy with regards to how we will do it here. And I think we in our country would learn a lot from your experiences and how you were able to continue about with almost with a new normal, a new with the old normal and the new normal being intermelded together. Dr. Oliveros, with regards to doing bariatric surgery at this point in time in our in local setting, would it be a wise move to do? Would it be wise to hold it off first, or do we continue? Do we try to pursue what our Thailand colleagues has been doing already?
Oh well, I'm very glad Sutep presented his experience in Thailand, because it's something we should copy. I mean, around Asia, you know, here in the Philippines, we're having at least 2,000 COVID cases a day. Would you believe it? So I don't see how we can start with bariatric surgery in the OR. Not only are the patients at risk, but also the surgeon is at risk, and it has happened. The OR staff getting infected. So what Dr. Sutep has presented is something we should copy, but I still think we should proceed very slowly and cautiously before going back to our regular bariatric surgeries.
Thank you very much, sir. So I guess we don't have enough time for this session, and the inputs from our speakers, Professor Sutep and Dr. Oliveros, has been very, very engaging and very, very useful for our practice. Hopefully, we can learn a lot from our friends from Thailand, from their experience, and we will all be able to handle this pandemic together as one ASEAN neighborhood, so to speak. With regards to from the Philippine Society of Metabolic and Bariatric Surgery, we would like to thank PALES for giving us this opportunity to have this presentation and discussion on bariatric, metabolic, and pandemic. Congratulations again to Dr. Ike Mendoza for being our new president in PALES, and Dr. Boytan, thank you very much for all your help with our society as well, with also with ELSA, and let us continue our friendship and our collaboration. Thank you very much, sir.
Thank you.
Thank you very much. Thank you. Hi, congratulations. Thank you, everyone. Thank you, Palace.
Thank you, Sutep. Thank you, Paulo. Edward, excellent session.
Congrats, Ike.
Thanks.
Okay, Ray.
Good morning, everyone. Jeff, are we online?
Yes, we're now online. You can
Can you
start,
hear
Ray.
me?
Yes, we can hear you. Start now, Ray.
Okay. Okay. Good morning, everyone. I'm Dr. Ray Sarmiento. Um, I'll be moderating the session on managing complexities in surgical endoscopy. So we have three distinguished guests, lecturers for today. They are local experts. We'd like to highlight them because we all know that the training in surgical endoscopy is usually done abroad, but as you can see, I have a lot of surgical endoscopists now locally, and we can augment the lack of training in surgical endoscopy in the country by having these new guys in the in the field of surgical endoscopy. So, without uh, further ado, I'd like to introduce the first speaker. Dr. Roselio was the third surgical endoscopist who came home. He had his training in Cebu, general surgery, and had a surgical endoscopy and minimally invasive surgery, advanced minimally invasive surgery at the Chinese University of Hong Kong, the Prince of Wales Hospital. And he had been very active with PALES, been president of the chapters of Cebu in terms of PSGS, PALES, PCS. So Dr. Rosello will give us a talk on the management of gallstone pancreatitis. So, Dr. Rosello, please take it away.
Yeah. Thank you, Ray. Can I share my slide?
Yes, Doc.
Yeah. How do I share my slide? Just one moment. Do you see the slides? No.
No, sir. Just click the share screen, then your slide. Okay.
How's that?
Okay na po.
Okay. Okay. So good afternoon to everyone. Thank you, Ray, for the very kind introduction. Congratulations to the organizing committee of PALES for a very well organized virtual congress, especially to Dr. Jeff Domino and Dr. Raymond Ong. So this afternoon, still morning, I'll be talking to you about endoscopic management of biliary pancreatitis. Sorry, I'm still learning about this. Biliary pancreatitis is also known as gallstone pancreatitis. It's a complication of biliary calculus disease, along with it is one of the more severe complications of gallbladder stones and cholecystolithiasis, along with cholangitis, Maritz syndrome, and cholangitis and acute cholecystitis. So the pathophysiology of gallstone pancreatitis or biliary pancreatitis includes a common channel theory for a common channel, which I will try to discuss in a little bit. There should be a reflux of infected bile. There have been studies of reflux of uninfected bile, and apparently it does not really cause biliary pancreatitis. And of course, obstruction of the pancreatic duct. As far as the common channel theory is concerned, from what we know, the
a common channel occurs in about 90% of individuals, and in about 9%, 9 to 10%, there is no common channel. So as you can see in this illustration, there is no common channel that could be seen in about 9 to 10% of patients. For those with a short common channel, these are the patients who are believed to have easy spontaneous passage of the common bile duct stone. However, we know that in about 85% of the patients, they may develop severe pancreatitis. From what we know, based on previous studies, severe pancreatitis can occur in as much as 15 to 30% of patients with biliary pancreatitis. Spontaneous passage of stones occur in about 40 to 50% of the patients. However, these severe pancreatitis is something that we try to avoid, and that's the reason for the early management and urgent and definitive management of these patients. Despite having a common channel, it does not necessarily mean that this common channel prevents a patient from having biliary pancreatitis. It is just that the symptoms usually develop late, and a bigger stone is necessary. There are other factors which cause biliary pancreatitis, and from several studies, one is males. For some reason, males are more predisposed to develop biliary pancreatitis, and another factor is the size of the stone. So smaller gallstones are associated with the increased risk of acute pancreatitis. And this is one of the reasons why, if we look at our textbooks, one of the indications for cholecystectomy are patients with symptomatic gallstones having an average size of stone less than or equal to 0.5 centimeters. I will try to elucidate and give you some examples why the smaller stones tend to cause biliary pancreatitis, while the bigger ones do not immediately present with biliary pancreatitis, not unless it has been a long-standing huge stone that it has migrated all the way down and it has dilated the common bile duct all the way to the end. So as you can see in this, the images here, the leftmost image here, the leftmost image is an image of a normal ERCP, or a normal biliary and pancreatic duct. Just a little bit about ERCP. The scope has an average size of about 12 millimeters. So as you can see in the image on the left, the common bile duct, the normal size of the common bile duct on ERCP, which is measured as the internal diameter of the common bile duct, is only about 6 millimeters, while the pancreatic duct, or a maximum of 6 millimeters, while the pancreatic duct only measures 1 to 2 millimeters. So remember that the duodenoscope is about 12 millimeters in diameter. In this image in the middle, you can see that this is a post-cholecystectomy patient who has a dilated common bile duct with a bile duct measuring, with consideration to the size of the scope, this is estimated to be about 7 to 8 millimeters. There is a stone in the distal common bile duct here, and you can see that the pancreatic duct is now dilated, measuring about 4 to 5 millimeters in diameter. This stone is in the distal pancreatic duct and causing obstruction of both the pancreatic duct and the common bile duct, causing the dilatation in this post-cholecystectomy patient. The stone is easier to visualize here when we cannulate the pancreatic duct with a guide wire, and you can see that these are the smaller stones that cause the biliary pancreatitis. In this image, these are a series of images where in the common bile duct, all of these 4 images have markedly dilated common bile ducts. Again, on the leftmost image, you can see that it is a normal ERCP. And you can see in this image that we have a stone which is approximately 10 millimeters in diameter. In another image, you have a stone which is approximately 7 millimeters in diameter. And none of these patients actually presented with pancreatitis. Even with this patient, because the bigger stones do not usually get lodged in the distal common bile duct or in the common channel. In this image, you can see that there are a couple of stones. The common bile duct is dilated to about 20 millimeters. The largest stone measures 18 millimeters. And there are several large stones all the way to the common hepatic duct, but still it does not reach all the way down to the common channel. In another image, you can see that this is a case of a Meritzi syndrome wherein we have a 2.2 centimeter stone. And you can see on the image on the right that the pancreatic duct is still of normal diameter. Diagnosis of biliary pancreatitis is very important. And what's important is to get the history, having some fever, history of alcohol intake, pain prior to jaundice. These are important parts of the history. And as part of diagnosis of biliary pancreatitis, an elevated direct bilirubin and elevated pancreatic enzymes is necessary. But then it is not all patients that have elevated direct bilirubin and elevated pancreatic enzymes doesn't necessarily or automatically mean that they have biliary pancreatitis, because other diseases, including periampullary malignancy and other causes of pancreatitis, like alcoholic liver disease, alcoholic pancreatitis, may still cause obstructive jaundice. So any other cause of pancreatitis with the edema of the pancreas compressing on the common bile duct, it can still cause elevation of the direct bilirubin. So what's important in the diagnosis of biliary pancreatitis is imaging. So ultrasonography is a first step in imaging because it can tell us if there is dilatation of the common bile duct. It will tell you if there are stones in the gallbladder. It can give you an average or an estimate size of the stones. Usually the smaller stones are the ones which will fall into the common bile duct because they're the ones that go through the cystic duct first, and they can cause pancreatitis. There is no question with regards to the specificity of these diagnostic procedures: ultrasound, CT scan, MRCP, EUS, and ERCP. There's definitely no question about the specificity, because if they're able to determine stones, then most likely there is a common bile duct stone. And all of these have specificities greater than 90%. The big question is the sensitivity. So ultrasound is reader dependent and depends on the equipment of the sonologist, and only has a sensitivity of reported to be between 50 to 75%. So that's because of it's a reader dependent. CT scan would also depend on how many cuts it could do. It could be as sensitive as 75 and as much as 85%. The main advantage of CT scan is it is good at visualizing complications caused by biliary pancreatitis. And I will try to enumerate the complications later. MRCP has the distinct advantage of not having to expose the patient to any contrast and not to expose the patient on any radiation. It is one of the least invasive ones, aside from ultrasonography. It's one of the least invasive ones. And the main advantage of it is this sensitivity exceeding 90%. So anything which is not or below 90% sensitive is generally unacceptable. So if we want to diagnose choledocholithiasis, it is not going to be CT scan because the sensitivity can only go as much as 85%. So MRCP, EUS, and cholangiogram are considered as good enough to determine the presence of choledocholithiasis. So MRCP has a sensitivity of about 90 to 94%. And the advantage is it does not require contrast to be performed, and it doesn't expose the patient to any form of radiation, and it is not invasive. Another one which has no, doesn't expose the patient to any contrast is endoscopic ultrasonography. This is fairly new and it is not readily available in our locality. However, this is one of the new kids, the new kids of endoscopy, and it is very promising. It is one of the most promising features of endoscopy as of the moment. The main advantage of endoscopic ultrasonography is trying to find out if there are presence of bile sludge and microlithiasis. Bile sludge and microlithiasis are now known as the causes of what we previously know as idiopathic pancreatitis, or idiopathic etiology for the pancreatitis. So what we used to categorize idiopathic pancreatitis as much as 60%, it has gone down to about 40%, and now it's even lower with the advent of endoscopic ultrasonography, because they're able to determine the presence of microlithiasis and bile sludge in the distal pancreatic duct or distal common bile duct. Another advantage of endoscopic ultrasonography is that it is ideal for managing complications of biliary pancreatitis, as I will try to discuss later. ERCP. ERCP has the main advantage of being both diagnostic and therapeutic. It is considered as one of the gold standards. As we know, the gold standard for determining common bile duct stones is still cholangiogram, and ERCP is a form of cholangiogram, and it has a distinct advantage of being diagnostic, finding distal common bile duct stones and managing it immediately. So the complications with biliary pancreatitis are divided into pancreatic complications and systemic complications. I will not try to enumerate each one, but we have to remember that there are several complications of pancreatitis, and this is the main reason why we have to manage this early and definitively. Time is very important. Timing of management of biliary pancreatitis is very important to avoid these numerous complications. We cannot risk that 15 to 30% of the patients will eventually develop severe pancreatitis and may develop these complications. As you can see, for the pancreatic complications, a lot of these can be determined by CT scan, and a lot of these can be managed with endoscopic ultrasound. So endoscopic ultrasound, as mentioned earlier, is great for determining the presence of microlithiasis. It can also determine periampullary lesions, the very small ones, and it can diagnose it and do biopsy on periampullary lesions. It can tell us the presence of chronic pancreatitis in the form of rosary bead appearance. More in our locality, it looks more like a chorizo rather than a rosary bead. It can determine the presence of pancreatic pseudocyst, as seen here in this image. This is an image of a pancreatic pseudocyst, which can be drained using the linear array of the endoscopic ultrasound. Peripancreatic abscesses can be managed. A stent can be inserted, and eventually these peripancreatic abscesses or pancreatic abscesses, if they develop into pancreatic necrosis, they can be drained, and a stent could be left in place, wherein debridement of the area with the pancreatic necrosis can be performed. Endoscopic ultrasound in patients with microlithiasis or patients with mild pancreatitis can be very useful in selection for patients who will eventually need to undergo ERCP. So instead of discussing more about the complications, we'll try to discuss about the ERCP. So there are patients wherein the indication for ERCP is definite. There is no question whether ERCP should be performed or not. It includes patients with cholangitis and severe pancreatitis. These patients definitely need ERCP. As far as the timing for the management of choledocholitis and biliary pancreatitis is concerned, the ideal timing is between 48 and 72 hours. Earlier, for patients with cholangitis, it should be, a semi-emergent procedure. So there is a severity scoring for pancreatitis. However, most of these are not very useful, except for the Apache 2, which can determine a severe pancreatitis, differentiate between a severe pancreatitis and a mild or moderate pancreatitis. Severe pancreatitis definitely need urgent ERCP, early ERCP. So if the patient comes to you still in abdominal pain, jaundice, persistent jaundice, still in abdominal pain, then definitely an ERCP should be performed early. However, if the patient has signs of pancreatitis and bile duct obstruction, however, the symptoms are resolving, then those are the patients that you would want to do more definitive imaging, whether MRCP or endoscopic ultrasound, to determine the presence of small stones in the distal pancreatic duct if the stones are still there, knowing that approximately 40 to 50% of the patients may have spontaneous stone passage. MRCP and EUS are good enough to tell you if the reports on the MRCP and endoscopic ultrasound show that there is no more stone in the common bile duct, then we will assume that the stone has spontaneously passed, and ERCP may not necessarily be indicated. However, cholecystectomy is still advocated within the same admission to prevent recurrence of this disease. So imaging is the key. So in patients with mild symptoms, or even or mild or moderate pancreatitis, EUS and MRCP would be able to tell you if common bile duct stones or distal pancreatic or distal common bile duct stones is still present as a cause of pancreatitis, and that would indicate whether an ERCP is necessary or not. The incidence of negative ERCPs, as mentioned earlier, is between 40 to 60%. So there have been several studies. I'm not going to fill up this slide with photos of previous studies, which shows that ERCP in the past, as early as early 1990s, they performed ERCPs in all patients with biliary pancreatitis. Dilatation of the bile duct as an indication, pancreatitis, and direct bilirubinemia, more than 2%. They do ERCPs on everyone and find out that as much as 40 to 60% will have no more stones in the common bile duct. The main issue why most papers, recent papers, are trying to avoid ERCP is the cost and the complications. So the complications of ERCP, there are three major complications. One, the most dreaded one, is bowel perforation. It occurs in about 1 in 1,000 to 1 in 2,000 patients. Bleeding occurs, depends on the experience of the endoscopist. Majority of the bleeding spontaneously stops and can be controlled endoscopically. In my own experience, I've done over 6,000 ERCPs, and I've had to open one patient due to significant bleeding. But the complication which we talk about with regards to biliary pancreatitis is the third complication of ERCP, which is also pancreatitis. So three major complications: perforation, bleeding, and pancreatitis. So how could we treat biliary pancreatitis with a procedure which also has a pancreatitis as its complication? So those are the two things that they mentioned about the ERCP: cost and complication. I will try to first show you a video of an ERCP which I recently performed. I performed this ERCP just last July 14, and this patient actually presented with biliary pancreatitis. She's a 30-year-old patient. I'm sorry if the name is a black spot at the side. I had to cover the name. So in this patient, I was able to inject some contrast into the ampulla. You can see that the ampulla is slightly bulging. That's not normally looking. And I had a fairly difficult time cannulating this one. So I was able to inject some contrast, but I could not push the sphincterotome into the common bile duct, although the contrast that was injected definitely went into the common bile duct. So instead, I used a guide wire. So you could see the guide wire with the black hydrophilic tip. And what we did was just use a guide wire to cannulate. And you can see on the image here that the guide wire has gone into the common bile duct. And you can see that there is a small stone in the distal common bile duct, which is obstructing. In these cases, I still tried to push the sphincterotome to the ampulla to be able to do a sphincterotomy, but the stone that was seen on the cholangiogram is lodged at the ampulla, and I could not push the sphincterotome beyond the ampulla, no matter how I tried. So what we do here is we try to do an exchange and leave a guide wire inside, and instead of using the sphincterotome to do the sphincterotomy, we can use we can do a pre-cut sphincterotomy using a needle knife. So you can see that despite the effort that I had trying to push the sphincterotome into the ampulla, it just won't go in. This is the reason why some of the patients with biliary pancreatitis will develop ampullary edema, and it will cause edema of the ampulla even after the ERCP and cause mechanical obstruction of the pancreatic duct despite the ERCP or despite the relief or removal of the stone. So now you can see that I'm using here now a needle knife to start the sphincterotomy. I use the guide wire as a guide on the direction of the sphincterotomy. But once I could determine where the common bile duct is headed, we enlarged the sphincterotomy, and definitely we could see a small stone. It's only about 4 millimeters to 5 millimeters at the lodge at the ampulla. So now that we know where the direction of the common bile duct is, and we're definitely sure that there's a stone there, then we can do the pre-cut sphincterotomy freehand. It is not always that I get to have a guide wire as a guide or a chopping board to do pre-cut sphincterotomy. But in this case, I guess I was fortunate enough to have that guide wire in prior to doing a pre-cut sphincterotomy. So we just extend the sphincterotomy to be able to remove the stone, and the distal common bile duct stone just spontaneously comes out. And now we can do a complete cholangiogram. We can use the needle knife to inject contrast into the common bile duct to visualize the common bile duct completely and find out if there are any other stones or microlithiasis in the common bile duct. And once we do that, we can change and go back to the sphincterotome and complete the sphincterotomy. It is important to do a complete sphincterotomy when we're doing ERCP, because if the sphincterotomy is not complete and there is still some muscle fibers, the edema after the procedure may cause obstruction of the common bile duct, mechanical obstruction. So you can see here in the cholangiogram that there are no other stones, and there was only one stone that was lodged in the distal common bile duct. The next thing that I will try to show you is still that of a controversy. And this is one of the ways to avoid pancreatitis after an ERCP. So as we know, There are two issues with regards to ERCP. One is cost, and the other one is pancreatitis. We use a balloon to clear the common bile duct, and this is the thing that I mentioned. So we can see here that this is the, as I'm pointing out, that's the common bile duct, and the pancreatic duct, which is actually very small, is just an indentation that we could see here. So you can see that what I'm doing is a pancreatic duct cannulation using the guide wire. So you can see the guide wire in here going into the pancreatic duct. This is the common bile duct. This is the pancreatic duct. And what you'll see next is still a controversial way of doing or trying to manage or trying to reduce the incidence of pancreatitis after ERCP, wherein I cut or I do a pancreatic duct sphincterotomy and try to prevent edema, post ERCP edema. I also do a pancreatic duct sphincterotomy in most or all of the patients that I have, wherein I inject contrast into the pancreatic duct, and I could see that there is poor drainage of the contrast. We know that there is a pathophysiology to having post ERCP pancreatitis, and pathophysiology includes mechanical obstruction. Usually, it's due to the edema or to retain common bile duct stones. So if there are stones left in the common bile duct and the endoscopist assumed that there was only one and didn't clear it for microlithiasis and other common bile duct stones, so it can cause mechanical obstruction and can cause post-ERCP pancreatitis. But the most common one is ampullary edema after manipulation. So this one we can avoid by doing a pancreatic duct sphincterotomy or inserting a pancreatic stent. So there has been several papers with regards to this, and one of the papers wherein they had a study of about in this paper here done in China. It was published in 2017. They had 230 patients in a span of only 2 years, wherein they did pancreatic duct stenting. They did stent. Most of the stents that they placed were actually pancreatico-nasal stents. So these pancreatico-nasal stents, the main advantage is after a couple of days, patient doesn't have pancreatitis or the pancreatitis resolves, you can just remove the stent when it goes through the nose of the patient. So it's easy to remove. You don't need to do another ERCP or endoscopy to remove the pancreatic duct stent. So the pathophysiology for post-ERCP pancreatitis includes mechanical obstruction, hydrostatic injury to the pancreatic ducts, usually because the endoscopist was too eager in pushing the contrast into the pancreatic duct. And the third one would be a chemical or allergic reaction due to the contrast. So as I mentioned earlier, in my experience, whenever I see that there is still some contrast that is left in the pancreatic duct, I would do a pancreatic duct sphincterotomy. So these two are images of pancreatic duct stenting. This is a nasopancreatic duct stent. With regards to pancreatic duct stenting, the main indications that there is for, if we try to read on the literature and on the text, the main indication for pancreatic duct sphincterotomy is actually just chronic pancreatitis. So chronic pancreatitis, which includes stenosis, calculi in the pancreatic duct, or in rare occasions, there is disruption of the pancreatic duct due to complications of pancreatitis, surgery, or trauma. But I believe that ampullary edema should also be an indication for a pancreatic duct sphincterotomy. So there have been a couple of papers written about pancreatic duct sphincterotomy, and most of them would mention that these are actually fairly safe procedures. In this paper that was presented as early as, or published as early as 1994 in gastrointestinal endoscopy, they had 56 patients in a span of 4 years. And they mentioned that pancreatic duct sphincterotomy is a safe procedure, and the number one complication would be bleeding. Another paper presented in or published in September 2009 from Korea mentioned that they had 46 patients in a span of 8 years. So it's not that much, but they tried to establish the safety of um, pancreatic duct sphincterotomy. So the biggest experience that we know of pancreatic duct sphincterotomy is actually published by the Australians. And in one institution, they've done more than 120 cases in a span of 4 years. And in the same institution in Westmead, Australia, they had this publication in 2013 that they had a 2-year experience of performed by 4 experienced endoscopists having experience of more than 3,000 cases each. They had 73 patients, and this is the biggest study. And they mentioned that it doesn't really, needle knife sphincterotomy does not increase the risk of pancreatitis with difficult biliary cannulation. And in this other paper, which is authored by our fellow in Cebu doctors, this was performed by a single endoscopist. With we had approximately we had actually 72 patients in 4 years, wherein we did pancreatic duct sphincterotomy, and we just tried to elucidate the safety of the pancreatic duct sphincterotomy and the value to access the common bile duct in difficult cannulation. The main complication of pancreatic duct sphincterotomy would be bleeding. So in conclusion, since I've taken up so much of his time, what's important with biliary pancreatitis is to understand the pathogenesis. So a common channel is necessary, and it affects between 85 to 90% of the general population. And infected bile is usually apparently a necessity to develop biliary pancreatitis and pancreatic duct obstruction. Other factors, so these are things that you should be wary about. If your patient with biliary pancreatitis is a male, or on ultrasound they have small stones, then you should be more aggressive with the management and try to do early ERCP, because they're the ones who have a tendency to develop more severe complications and severe biliary pancreatitis. As mentioned earlier, imaging is the key to the diagnosis. So what's acceptable in imaging common bile duct stones and trying to rule out common bile duct stones is MRCP and EUS. And it is important to select the patients, try to see which patients have severe pancreatitis. There's no need for further imaging. You can see that patient has severe pancreatitis, dilated common bile duct or common bile duct stones on ultrasound or CT scan. Then you don't need to wait for MRCP or EUS. You can just go directly and manage it with ERCP and try to manage it early to avoid the complications. Patients with cholangitis and severe pancreatitis ideally should have an early ERCP. Early is between 24 to 48 hours. And all the pancreatitis, biliary pancreatitis, you should be able to decide on what to do with the patient within the first 72 hours. If the pancreatitis is mild or even moderate and you require further imaging, then you can do it with MRCP or EUS. EUS would still be the best at finding microlithiasis. What's important is really stone clearance to prevent recurrences of biliary pancreatitis, and cholecystectomy is necessary, ideally within the same admission in patients with gallstones on ultrasound or any imaging. And although it's still controversial, I would ask you to consider the use of pancreatic duct stenting and sphincterotomy to prevent pancreatitis as a complication of the RCP. Thank you. And if there are any questions.
Thank you, Don. Thank you for that very comprehensive lecture. Maybe we can entertain questions later once the two other speakers are done with their lectures. So let me proceed with the next lecture. Our next speaker is a graduate of the De La Salle University Medical Center, training in general surgery. She had her fellowship in upper GI surgery and surgical endoscopy at the Showa University, Tokyo, Japan, under Professor Inoue, and had her clinical fellowship in Rizal Medical Center Surgical Endoscopy MIS fellowship program, and had further training in basic and interventional endoscopic ultrasound under Professor Pradem Chai in Bangkok, Thailand. She'll be giving a talk on, well, actually a video presentation on the management or endoscopic management of walled-off pancreatic necrosis as a complication of pancreatitis. Dr. Cañones, Arlene Cañones, please take it away.
Thank you, sir. Am I coming in loud and clear po?
Loud and clear.
Okay. So let me share my slide. So thank you, sir. Okay. Hello?
We can hear you, Arlene. Yes, we
okay,
can hear you.
Sir. Okay, so first of all, I would like to thank PALES and its organizing committee for giving me the opportunity to give a lecture amongst my mentors and the MES pillars of the MES in the Philippines. It's truly an honor and a very humbling experience. So I am tasked today to give a video presentation and actually small discussion on the endoscopic management of walled-off pancreatic necrosis. So I have no disclosures. So the objective of this presentation is to give overview of necrotizing pancreatitis and to show the options for management. And to present a case on endoscopic management of walled-off pancreatitis and show its advantages, such as feasibility, efficacy, and safety, and to present complication in its management. So pancreatic necrosis is a part of a moderate or severe acute pancreatitis and occurs in 5 to 10% of patients with acute pancreatitis as per the 2012 revised Atlanta classification. And according to Singh et al. In 2018, it has a mortality rate of 20 to 30%. So to review the 2012 revised Atlanta classification, pancreatic fluid collections are divided based on the necrotic contents of the fluid collections and the timing, which is since the time of the initial symptoms of the patient. So acute necrotic collection occurs less than 4 weeks since the time of the initial symptom and is located within the pancreatic parenchyma or the peripancreatic area. Radiologic features, it shows an homogeneous contents. Although sometimes during the early stages, it's still homogeneous because of the non-liquefied contents. And the most distinct characteristic of the ANC or the acute necrotic collection is that it has no wall, as you can see in the picture. So the walled-off pancreatic necrosis, which occurs more than 4 weeks since the initial symptom of the patient, is also located within the pancreatic parenchyma and or the peripancreatic space. So just like the acute pancreatic necrosis, it is also seen in the CT scan with inhomogeneous densities because of the non-liquefied contents. But the difference is that it has a distinct wall, as you can see in the picture shown. So the treatment for this, so we just basically follow the basic tenets of the pancreatitis management, which is proper hydration. So for these patients who have a moderate to severe acute pancreatitis, it is advised that these patients will be admitted to the ICU. It is also best to give early nutrition for these patients to decrease morbidity and mortality. Although in some papers, giving of antibiotics is still debatable, since they advise to give antibiotics in the presence of infection. So when is emergency ERCP indicated? So as Dr. Roselio discussed earlier, the presence of severe cholangitis or the progressing disease is an indication for emergency ERCP. But for pancreatic necrosis or for pancreatic collections, the dilemma is when to drain or not to drain. So we follow the step-up approach. So in the presence or in the background of having a pancreatic fluid collections and in patients with SIRS or sepsis or organ dysfunction, we follow this step-up approach of doing drainage first, either percutaneously or endoscopic. And then if the patient does not improve, do the minimally invasive necrosectomy, either by laparoscopy or video-assisted retroperitoneal debridement, or the endoscopic transgastric necrosectomy. And if all else fails, do the open necrosectomy. So, of course, as much as possible, we don't want to do the open necrosectomy because it has a 50% mortality, as Matthew et al. In 2014 indicated. And it is reminding me of the patients I had during residency when we bring the patients to the OR repeatedly after a few days and then do several debridement and then the patient usually expires. So this Bogota bag we would use to do the open close and to facilitate an easy exploration again. So the video-assisted retroperitoneal debridement is the advised minimally invasive technique wherein following the step-up approach, we do the drainage first. So inserting the drainage into the left lateral, posterolateral area, which is the most accessible to the necrosis. And then if the patient still shows SIRS or sepsis, you do the incision following the catheter tract. And then you insert the laparoscope inside the created cavity to facilitate your debridement using your laparoscope as your eye inside the cavity and with your forceps and your hand to do the debridement. So the more promising and least invasive of them all is the endoscopic step-up approach. So this is also a natural orifice transluminal approach, which consists of transluminal drainage and debridement. So totally no incision at all. So Haney et al. In 2019 stated that there's a positive benefit for endoscopic treatment in terms of lesser hospital stay, lesser multiple organ failure, and lesser fistula creation. Although the same paper and some of the major papers on necrotic pancreatitis says that there's no significant differences in mortality between the endoscopic and the MIS or the surgical approach. Early this year, in January, a group from Mayo Clinic headed by Dr. Oblizajek published a paper about endoscopic intervention for early pancreatic necrosis, meaning they do the endoscopic step-up approach for pancreatic necrosis of less than 3 weeks, as long as there's a presence of a partial wall. So let me present to you a case we actually did during the ECQ. So this is a 31-year-old male who was referred to us from Alder Hospital due to epigastric pain and jaundice, which started 2 weeks prior to admission associated with undocumented fever. This patient was actually admitted in the other hospital and was managed conservatively for pancreatitis for 1 week, but was referred and transferred to our institution and Rizal Medical Center due to persistence of jaundice, abdominal pain, and on and off fever. So he was transferred for continuation of care. So the patient presented at the ER with the following vital signs and PE. So the patient came in with stable vital signs. And the pertinent labs showing that the patient had leukocytosis, the patient has had elevated bilirubins and transaminases, alkaphosis elevated, the lipase is elevated as well. However, the upper abdominal ultrasound showed that the contracted gallbladder with a 1.6 lithosis within, and despite the CBD being dilated, there was no lithosis noted, and IHDs are not dilated. So protocol in our hospital in Rizal Medical Center is if on initial ultrasound and the patient is jaundiced but no obstruction was seen, we need to do further evaluation to know the cause of the jaundice. So we requested for a triphasic CT scan. So this is the arterial view of the arterial phase of the CT scan. So the gallbladder was thickened with no lithosis. However, the CBD is dilated with suspicious lucency at the distal CBD. And there was a note of an enlarged pancreas, which is heterogeneously enhancing, with a peripancreatic fluid, which is encapsulated, and it's extending to the lesser sac and inferiorly to the left anterior pararenal space. So the admitting impression during this time was biliary pancreatitis in moderate cholangitis with high risk for CBD stone with the following basis. So of course in the wards, we admitted the patient, although I think that time we didn't have ICU available. So we admitted the patient to acute care. The patient was still jaundiced with on and off abdominal pain and fever. So the dilemma during this time is to do if the patient is having cholangitis or if the patient has infection of the pancreatic fluid collection. So the game plan was to do ERCP and EUS. So in EUS, in ERCP, the patient had dilated CBD, but we didn't see any lithiasis. So we're considering past stone. There was no pus, so we just did in sphincterotomy in balloon trolling. So knowing that the patient is not cholangitic, endoscopic ultrasound is then done, and we saw that there's a fluid collection posterior to the proximal stomach with capsule and the debris. So the picture at the right side shows so actually this is the best image that we can get out of the EUS. So the cystic capsule is not yet that matured, and there's a fluid debris within and the solid debris at the rightmost part. So the plan is to do drainage during this time because we are thinking that the infection is coming from the cyst. So a gauge 19 EUS needle is then inserted, and then the guide wire is inserted to facilitate exchange of the catheters. So to create a fistula, we inserted needle knife, and then with coagulation, the fistula is created. Through the needle knife is then poked through the abdominal wall, the gastric wall, straight to the cystic wall. So as you can see, the fluid has still debris inside. After creation of the fistula, a plastic stent, a double pigtail stent, was then inserted. So if you can see at the rightmost part of your screen, so that's the stent being deployed. So that's the distal part of the stent deployed. Knowing that the stent will not be enough to drain the debris, we decided to put 2 more stents. So we dilated first and then put 2 more to maintain the patency of the fistula tract. So those are the 3 pigtail stents, and that's the EUS probe at the rightmost of the screen. And you can see here that the debris coming out of the tract. So last look. So the cystic wall is now, so the fluid inside the cystic wall, the cystic cavity is now lesser as compared to the initial EOS. So the patient had resolving jaundice. We put the patient on clear liquids. However, 7th day post-drainage, the patient had persistence of abdominal pain and recurrence of fever. So we decided to repeat the CT scan, and this is what the CT scan suggested, that the patient has a progressive necrosis and that the pancreas is not as enhancing as in the first CT scan. So we decided to do a necrosectomy, endoscopic necrosectomy. So this is 16 days after the endoscopic drainage, the transgastric drainage. So the stents are still in, but we decided to just remove just one of the 3 stents just to facilitate insertion of the catheters. So this is actually insertion of the catheter in retroflexion because upon entry into the cavity, into the lumen, so we are using a forward viewing scope. So it's hard to maneuver when the target area is at the posterior part. So I had to do this under retroflex. So guide wire is inserted so to facilitate the insertion of the other catheters like the CRE balloon to dilate the tract. So this is the CRE or the controlled radial expansion balloon dilated up to 1 centimeter. So we dilated to 1 centimeter to prepare the tract for insertion of the scopes, which is the gastroscope, which is 8 millimeter, and the colonoscope. So this is, we changed the scope to the colonoscope, which has a larger channel. The colonoscopes has 3.2, 3.8 channels. So the advantage of leaving the 2 stents behind is that it will guide us to the tract. So this is, so that's the stent and then the dilated tract. And upon entry into the cystic cavity, we noticed the black contents, which is mixed blood clots and debris. So as you can see, it's still solid. So we just did, for the first necrosectomy, we just did the flush and the suction technique. So meaning we just flush and then got the affluent using the suction. So this is the other part of the cystic cavity. So the cavity is actually collapsing because of the suctioning. So there you can see on the left side, that's the necrotic part. So the advantage of having a scope inside the cavity is that you can see directly the contents and assess if there are other adjacent or major vasculature that is being injured, like this one. We noted that there was a pulsating, although non-bleeding vessel. So before going out, we coagulated this vessel using a hemostatic grasper. So it took a long time to for the grasper to come out because this is a long scope. Okay, so these hemostatic graspers are less than 1 centimeter big, so it's quite small. So the small vessels can be easily identified and then coagulated or grasped using these graspers. So actually, we also use this to remove some of the necrotic debris. But since it is small, it's hard to do your debridement using this small grasper. So since the necrosis is still solid, we decided to go back after 5 days. So this is the second necrosectomy. So during this time, the patient still had some abdominal pain and was still febrile, but he was stable all throughout. So as you can see, the debris is now more liquefied as compared to the first one, the first necrosectomy. So since the debris is more liquefied, it's easier for us to do the debridement using the catheters like the snare and the basket. So we did a total of 4 necrosectomy using endoscopic way. So this is the 4th endoscopic necrosectomy, which is after 30 days since the transgastric drainage. So we did the necrosectomy after an interval of 4 to 5 days. So this is how the cavity looked like after 4 necrosectomies. So the red part is actually the granulation tissue inside the cavity. And although there are some necrotic debris, we still managed to take it out and do completion necrosectomy. And decided to discharge the patient after 4 to 5 days. However, this patient developed upper GI bleeding on the 5th day since the last necrosectomy. So we returned to the OR and then do a gastroscopy, upper GI gastroscopy. We didn't find any bleeding inside the stomach, esophagus, and the duodenum. So although we anticipated that the bleeding was coming from the cavity. So upon entry into the cavity, we noted blood clots inside. So our theory is that the stent was abrading on the raw areas. So we just flushed and then identified some of the bleeders and did coagulation. And we just sucked out all the blood clots, as this will be nidus for infection as well. So this is how the other cavities look like. So the granulation tissue is intact with some debris inside. So we actually managed to take it out as well. So since our theory that the stent was causing the bleeding, we decided to remove the stent and then let the cavity shrink, and then do CT scan after 2 to 4 weeks. So this is the gastric part, of the gastric end of the stent. So by the use of the rat tooth, we pulled the stent out, and then the patient was discharged, fully improved and healthy after a few days. So the key points of this is that endoscopic step-up approach is feasible, effective, and safe. Although in the absence of the specialty and equipment, other options are available, such as the BARDs and the laparoscopic necrosectomy. But of course, as much as possible, we would want to do the endoscopic approach, since minimal may be the most optimal approach. And as surgeons, it is very important for us to do the proper response and timely response. So with our chairman, Dr. Ray Sarmiento, our program director, Dr. Arlene Abisinia, So this is the surgical endoscopy team with our nurse, endoscopy nurse, our anesthesiologist, our residents, and our fellows. So maraming salamat po and stay safe everyone.
Thank you, Arlene, for that wonderful lecture and very interesting. Can you hear me? So, guys, we still have one more lecture for endoscopy. Then a live surgery feed will follow after this. So the next speaker, the question, I have taken note of your questions. I will later ask them to the panel. Let's go first to the last lecture, not the least. Our next lecturer is a graduate of the Southern Philippines Medical Center General Surgery Training Program, had his clinical fellowship in surgical endoscopy and MIS in Rizal Medical Center, and had fellowship in interventional EUS at the Chinese University of Hong Kong, Prince of Wales. His director of endoscopy is Philip Chu, the guy who lectured us with in robotics on robotics yesterday. Without further ado, I pass on the floor to Dr. Jusil Cruz. He will be lecturing on. Okay, Jusil, take it away.
Hi, sir.
Okay. Hello, Jusil.
Good noon. Okay, good noon. My lecture is about endoscopic management of malignant biliary obstruction as adjunct to borderline resectable lesion. Actually, this is a very broad topic. So I'll just summarize everything about how biliary obstruction would help borderline resectable lesion to bridge for surgery. So when we say endoscopic management, endoscopic transpapillary instrumentation through ERCP, and the second is through EUS, or endoscopic image-guided instrumentation. When we say borderline resectable lesion, it's pancreatobiliary tumor, non-metastatic, preoperative borderline resectable by imaging. When we say malignant biliary obstruction, it entails periampillary around here, or extrabiliary, or maybe from the gallbladder, impinging the common bile duct, hilar, or questionable the intrahepatic ducts. So the question is, actually my lecture is about questions, when do you do ERCP-EUS guided bile duct drainage in patients with non-metastatic borderline resectable HPB lesions? So in ASGE and ESG guidelines, these are GI Society, they call it preoperative biliary drainage. But for me, I call it SD, stenting and drainage. Not Sara Duterte, it's stenting and drainage. Okay? For my discussion, I will differentiate the modality of SD in malignant biliary obstructions, its indications and recommendation, the definition of non-metastatic, borderline, resectable HPB lesions, role of SD in neoadjuvant therapy as bridge for curative surgery, is stenting drainage recommended for all or selected HPB lesions prior to surgery, an evidence-based recommendation for preoperative biliary drainage, practices, results, and controversies. For endoscopic modality for SD, we know the primary and the modality is ERCP. Okay, as you can see in the circled by the red circle, that's a stricture. Basically because it's eccentric, long, and then thin-walled. As you can see, it's like a rat tailing configuration. On the next picture, it's similar. And then you insert a stent. That's why I call it stenting, and you drain the bile duct. Okay? As you can see in the endoscopic view on the fourth picture. So in the guidelines, ERCP is a primary choice of biliary drainage in malignant biliary obstruction for selected patients. One is cholangitis, severe symptomatic jaundice, poor risk patients for delayed surgery or as a bridge for neoadjuvant chemotherapy. Second, primary endoscopic of choice for palliative malignant distal biliary obstruction. And third is primary of choice for decompressions of malignant distal biliary obstructions. These are guidelines by big society in Europe, are moderate in recommendations with good evidence. Now, the second is the EUS. So endoscopic ultrasound is used for biliary drainage. So as you can see in the picture, you have your EUS. As you can see, the transducer, there's no pointer, sorry. So the transducer is actually at the tip of the EUS machine. And then you can see the guide wire went into the left hepatic duct and then the insertion of your self-expanding metallic stent. There are 3 biliary drainage for an EUS can do. EUS guided HGS, your hepatogastrostomy stenting, your colidocoduodenostomy stenting, and then your rendezvous technique. Okay? For EUS bile duct drainage as guidelines, it's an adjunct for unsuccessful ERCP. And also it's an option for endoscopic biliary drainage in altered anatomy and inaccessible papilla. It's operator dependent with high learning curve, and then interventional EUS should be in a multidisciplinary HPB centers. So these are recommendations done by ESGE and ASGE, and also some of the society in Asia Pacific region. So for malignant biliary strictures, let's divide the strictures by location. So around the periampullary area, as you can see, so I made a table just to deduce everything in one table. So if we talk about periampullary tumors, these are pancreatic lesions, duodenal lesions, distal cholangioCA, and ampullary lesions. For stenting and drainage, only pancreatic lesions, borderline resectable is recommended because as a bridge for surgery, and you give the patient for neoadjuvant chemo RT. Okay? For jaundice resectable lesions, there's no need for pre-op routine biliary drainage. That's recommended by 3 gastrointestinal society. So no need for pre-op routine biliary drainage. The type of stent, consensus-wise, it's self-expanding metallic stent, not plastic stent. For duodenal lesion, the stenting and drainage is only just for biopsy, metastatic unresectable, and consider duodenal stenting when you have gastric outlet obstruction. Neoadjuvant, there's no. For other diagnostic, EUS is needed to differentiate whether it's duodenal in nature or periampullary tumor. So type of stents used, same, self-expanding metallic stent. For distal cholangioCA, there's no role for stenting and drainage except for biopsy, metastatic, and unresectable. No neoadjuvant chemotherapy. EUS is needed for tissue diagnosis. Very important for distal cholangiocarcinoma. Type of stent, self-expanding metallic stent. Whether covered or uncovered, it depends whether you have planned for patients for resection or no resection. But if you have no resection, you place an uncovered stent. If you plan for resection or you plan for if the patient presented with cholangitis initially and then you plan for resection, so you place a covered stent. For ampullary lesions, the stenting and drainage is reserved for biopsy, metastatic, unresectable. Neoadjuvant, there's no neoadjuvant. Diagnostic EUS is highly recommended. Resection is the best option because maybe you can distinguish whether your lesion is an ampullary or a pancreatic using an EUS. Type of stent, same, self-expanding metallic stent. For extrabiliary lesions, so these are extrinsic compressions of the bile duct. You have to consider there's an enlarged lymph node or metastatic periductal tumor. So these are metastatic lesions or malignant lymphadenopathy. Always remember, in cholangiogram, the strictures looks like smooth, eccentric. That's wrong. That's eccentric, not concentric, and thin-walled. The recommendation for extrabiliary lesions, you do your EUS-guided biopsy or your percutaneous biopsy. And then if you plan for treatment for the patients like lymphoma, you insert a covered stent. Because covered stent, you can remove the covered stent once the patient responds to your chemotherapy. Uncovered stent, very difficult to remove. For gallbladder strictures, our strictures in the mid-CBD or GB lesions presenting as jaundice or gallbladder lesions, gallbladder lesions presenting as jaundice signifies poor prognosis. So surgery is the mainstay for gallbladder carcinoma. Resectable with jaundice, resectable by scan, presenting with jaundice, they recommend stenting with neoadjuvant chemotherapy. That's NCCN guidelines version 2020. The stent use, self-expanding metallic stent. So actually that's a bridge for surgery. For hilar tumors, strictures that present in the hilum, so the primary treatment is surgery. Access resectability before, you have to assess first resectability before stenting and drainage. Consider scan artifact when you do a stent. The use of preoperative biliary drainage of the future liver remnant and contralateral portal vein embolization should be considered in cases of small future liver remnant. So actually that's the reason why we preserve the good liver, embolize the disease or with the lesions, and then you increase the future liver remnant of the patient. So now the stenting and drainage, there's no routine preoperative biliary drainage for hilar cholangiocarcinoma, except for very select case giving neoadjuvant chemo-RT bridge for liver transplant. And then, sorry, it's suggests if you have for drainage for hilar cholangiocarcinoma, ERCP plus or minus PTBD. Consider the bismuth type, whether it's bismuth 1 and 2, ERCP, higher bismuth, I think more of PTBD. So in conclusion, so for borderline resectable HPV lesions, endoscopic treatment is very important because it helps in establish the diagnosis and identify the stage of the disease. Then very important also for this endoscopic management, not only for therapeutic, but also for diagnostic. You can get tissue sample by ERCP using your brush biopsy, or if you have a cholangioscope, you can directly do intraductal biopsy. Or if it is around the bile duct or outside, you can do your EUS FNA using your needle and take out the biopsy. Very important. And then you determine whether it is resectable by scan, whether it's borderline resectable or non-resectable or metastatic. Then if you have these two criteria, your scan, your imaging, sample, then you can institute your treatment to the patient. Okay. Thank you, sir. That's all my lecture.
Thank you, Giselle. Very interesting lecture. Okay. Since we're running out of time, maybe we can entertain a few questions. There are most of the questions are in the Q&A box are answered by our panelists, but Dr. Mondivera asked me to give him the floor for a question. Dr. Divera.
Yes. Thank you, Ray.
Yes, sir.
First of all, congratulations to Don, to Arlene, and to Jusila. Very excellent and very comprehensive lectures. Pwede bang, ito lang, I have just several, sorry Ray.
Yes, sir.
Okay. Okay, yung ito, una muna kay Don, ano? Kasi ang pinaka-main punchline mo is to do pancreatic duct sphincterotomy in the management of acute pancreatitis. So, ang question ko is, did it really hasten or did it really affect the recovery of the acute pancreatitis?
No, Doc. No, this one, the pancreatic duct sphincterotomy is actually still controversial. And the use of pancreatic duct stent is already established. Yung pancreatic duct stent is established that it may help in patients with ampullary edema. However, pancreatic duct sphincterotomy is not completely acceptable yet. It is still controversial.
Okay.
Because it may at the same time cause further edema if not done properly, and it may cause bleeding. Okay. However, since I just presented it because I had a paper made wherein we've been doing pancreatic duct sphincterotomy, and we have very little complications regarding those things.
Maganda, you have a very excellent technique. and result. Anyway, then ang next question ko, di ba, sometimes in our intraoperative cholangiogram, yung mga routine, we could see reflux of the dye into the pancreatic duct, di ba? Is
Yes.
this a risk for developing pancreatitis? Kasi di ba ang sinasabi, one of the common pathophysiology or pathogenesis is reflux of the bile into the pancreatic duct. But we sometimes observe this in our routine IOC, no? Pero hindi naman sila nagkakaroon ng pancreatitis.
Yes, Doc. In patients with reflux of contrast into the pancreatic duct, there is always a risk to pancreatitis. One is because of the hydrostatic pressure. If the common bile duct is infected and then you're pushing contrast into the pancreatic duct, there's always that risk because you're pushing infected bile into the pancreatic duct based on pathophysiology. The increase in the hydrostatic pressure, if you're pushing it's just the same. When we're being trained, we usually use a syringe with a manometer so that we train ourselves to try to push the contrast very slowly. Ideally, it should be below 13 millimeters mercury, So it's below the venous pressure so that we don't push the contrast higher than the biliary or the pancreatic duct pressure so that it doesn't go into the venous circulation. Having allergy to contrast is also one of those things because the contrast in itself can actually cause pancreatitis.
And then last, yung para sa'yo, do you routinely insert a stent after ERCP cholecystectomy?
No, Doc. No.
Hindi. Okay,
no,
good.
No. It's not routine.
Okay, good.
Most of the ERCPs that I do for common bile duct stone, I try to avoid cannulating the pancreatic duct. And I just mentioned it. I don't.
No, what I mean the CBD. The
CBD, no, as well, no.
No. Okay, good.
If it's all clean, no stent.
Okay.
If there are still retained stones and we're not able to clear the stone, there is significant ampullary edema because we insert some contrast into the common bile duct. If it drains very poorly because of pancreatic or ampullary edema, despite having an adequate sphincterotomy, then I would be glad to put in a stent to prevent cholangitis. But if there's none, in most cases there is none, so I don't put in a stent.
Yeah. Okay. Then yung last para sa'yo, between MRCP and EUS, which would you prefer?
Currently, we're using MRCP because EUS is not available. Main advantage of MRCP is it is non-invasive. It does not require general anesthesia. It does not require sedation. So I would be, and the MRCP that we have is actually very good. The radiologist who reads the MRCP is an excellent person and easy to talk to. I would go for MRCP first before EUS.
Because it's as good as the EUS, ganun ba?
For microlithiasis, EUS is better for treating complications related to acute pancreatitis, as shown by Arlene. Congratulations, Arlene, for your nice talk. I would go for EUS. Kung meron na complications from the acute pancreatitis, I'd probably go for EUS just to see if there are any microlithiasis.
Okay.
But other than that, probably MRCP would be good enough.
Okay.
Especially if the patient is recovering.
Yeah, thank you, Don. Now, for Arlene, thank you again
thank you,
for your excellent, thank you, Don, for the excellent video presentation. And question ko lang, no? I saw na may nakita kang, you saw a pulsating vessel during your, I'm a bit worried about, since it's not bleeding, and I'm a bit worried about cauterizing with bipolar yung ginamit mo, di ba?
Yeah, in a way, yes, sir. Yes, sir.
Yeah. So medyo worried ako kasi sometimes kasi yung lalo pag naglalab ko and masyado kang zilo sa cautery sa gallbladder bed. Sometimes sinatamaan mo yung right hepatic artery and I've seen cases na nagkakaroon ng aneurysm. So I was wondering, could an aneurysm have developed? That's why there was bleeding, di ba, after your procedure. So medyo ano lang ako doon.
If you can see, sir, the grasper, it was very small.
Yeah.
Parang the grasper is less than 1 centimeter, mga 1 to 2 millimeters lang po yun. So,
Yeah.
actually, it was the gauge for us na alam namin na it was not one of the major vessels na matatamaan namin. Kaya malakas yung loob na mag-cauterize for that bed. Kaya yun, sir. Although, of course, one of the dreaded complication for debridement for this is bleeding pa rin, sir. And yun nga po, one of the cause can be aneurysm then. And I think one of the papers or one or two of the papers that I read, VARDS actually has more or more prone for aneurysm than endoscopic necrosectomy.
Yeah.
Kasi pag yung daw pong VARDS mas
mas
forceps mas malaki yung po.
Okay. And last para sa iyo, do you you inserted the balloon to dilate for 1 centimeter, di ba?
Yes,
or
sir.
Do you may mga protocol ba na that you can further enlarge it for better drainage, you know?
No protocol, sir. Actually, the main purpose of the dilation is to accommodate the scope, which is for the procedure we used gastroscope, which is 8 millimeter, and colonoscope, which is between 11 to 12 millimeters. So we just dilated the tract to accommodate those scopes for better debridement. Pero wala pong sinasabi ko up to how big. Although these balloons po can dilate up to 18 millimeters, the CRE balloons.
Yeah. And then just one curious question. Di ba, it's directly opening into the cavity. So are there food particles going inside your cavity?
So far, sir, surprisingly, yun din po ang isa naming discussion during the whole procedure and during the whole length of the management of the patient. Kasi although the what you call this, the tract is small, of course you can still have food particles there. Although mataas po kasi yung tract, nasa proximal stomach siya halos. And then the patient was not eating that much pa po. May actually one of the necrosectomy we inserted nasobiliary drain to flush the cavity. Hindi na lang po namin naipakita, but yun po, despite the stents, kahit po the tract is still patent, wala namang pong pumapasok na food particles, sir.
Yeah, good. Okay, thank you very much. Last lang.
Thank you rin.
Then kay Justin, it's not a question, but I'd like to fully agree and emphasize that for hilar biliary obstruction, I fully agree with your statement na ERCP may not be recommended kasi in PGH kasi I've seen several cases wherein for hilar obstruction they did ERCPs. Some are successful but not really totally drained. Kasi with hilar obstruction, di ba, sometimes you inject the dye under pressure and sometimes it goes to both the right and left. And then if you're not able to drain if you have an undrained segment or sub-segments, and this is really prone to cholangitis. And of those that I have observed na talagang most of them na nagko-cholangitis are usually severe and are attended with a high mortality. So in such cases, I fully agree with you that PTBD would be a better option. And of course, to drain that part of the liver that you plan to retain after a hepatic resection. So congratulations, everyone. Thank you, Rhea, for indulgence.
Thank you, sir.
Thank you, sir.
Yes,
It's a very intellectually stimulating change of ideas or discussion. There's just one question lingering in the Q&A box. It's from Dr. Flores. Maybe I can post this to the three of you. Do you see patients developing severe pancreatitis following ERCP? Can you comment on that, Dr. Cello, Lal, and Arlene and Josil? Most of you do the ERCP.
Yep, I see a
Hello,
lot
sir.
of patients. Hello. Yeah, can I answer it?
Sige, Don.
Yeah. There are a lot of patients who may develop pancreatitis. Majority, if we try to take a look at what's the incidence of pancreatitis, clinical pancreatitis after ERCP, it's only about 3 to 5%. Subclinical, meaning elevation of the enzymes after an ERCP. If there was no elevation of the enzyme after ERCP or prior to ERCP, as much as 30 to 35% will have hyperamylasemia after ERCP. But then it is subclinical, meaning patients will not have any symptoms to it. But after ERCP, approximately 3 to 5% may have pancreatitis after ERCP. How many of it will be severe? I haven't seen significant haven't seen a significant number of patients with severe pancreatitis after ERCP. Maybe because we're very careful on how we manage the ampulla. Second is maybe because I'm a little bit more liberal with pancreatic duct sphincterotomy. Third, maybe because we try to make sure that we've cleared the common bile duct. And if there's any uncertainty or if there's any significant periampullary or ampullary edema after your procedure, you can always put in a stent. Okay, so I guess those are the things that, or those are ways that we can prevent significant ERCP, post ERCP pancreatitis.
Okay, how about you, Josil and Arlene? Josil muna, South. Mindanao.
For mine, sir, I have 3 to 5%. I agree with Dr. Roselio. I have at least 3% with presenting with pancreatitis, post ERCP pancreatitis, but I haven't had a severe pancreatitis for my personal census.
How about you,
But
Arlene?
3 to 5% is very consistent, sir.
I mean, international standard. Most of our pancreatitis rate are within that standard.
In all honesty, my pancreatitis rate, I tried to compute it before. It's below 3%. Honestly, it's below 3%.
Okay, how about you, Arlene?
During training, sir, we've had one severe pancreatitis. So that's just one of the almost 400 ERCPs we do a year since we started the training program. So I think that's just less than 3% for the severe, which is also consistent with the international numbers, sir, of less than 1% of necrotizing pancreatitis or severe pancreatitis after ERCP.
Okay, if there are no more questions, guys, thank you very much for those.
If I may say, yeah,
thank
maybe
you, sir.
Ray might want to comment. Dr. Sarmiento, would you like to comment? There was a question posted by Dr. Arvin Briones in the chat box with regards to simultaneous ERCP and lab cole. We know that you were the one so first, but you were the one, so
okay,
the one who first presented it in DBW.
So we usually do same session ERCP lab colo, but of course we try to choose or try to select our patients, and I do the ERCP same session ERCP lab colo. Initially, I would do the ERCP first, and then do the lab colo. But now I can jumble up depending on the situation. I'll ask the surgeon to do the gallbladder surgery, then I'll do the ERCP. Especially if I know, or in the preoperative imaging, the ERCP will be, I think, will be not a difficult ERCP. So we have had a few numbers and haven't encountered any significant morbidity or mortality. The only difficulty would be wherein if it's a difficult stone and then the patient is scheduled for a same session gallbladder surgery, and then ERCP has bloated the bowel, as insufflated so much air inside the GI tract, I will not proceed with the gallbladder surgery anymore because I increase the risk of probably theoretically of injuring the small bowel during the gallbladder surgery. Any questions in the chat box? So, or in the Q&A box?
Hey,
Thank you, Kuya.
Sir, Dr. Erasmo.
yeah, just one question, if you still will allow me.
Yes, sir.
Yeah, congratulations first to all the presenters. So this is a big progress in our surgical training. The surgeons are now endoscopists, so we don't have to rely on our gastroenterologists to do the endoscopies for us. And we welcome and would like to thank Dr. Ray Sarmiento particularly for spearheading all of this endoscopic training in our for our local surgeons. And we hope that will come up more training programs for surgical endoscopy in the other parts of the Philippines. My question is for Dr. Arlene Chanyones. Now, when you do endoscopic transgastric necrosectomy, my concern is whether the posterior wall of the stomach is closely adherent to the pseudocapsule of that wall of necrosis. Because if that is not, if there's not much attachment or adherence between the two structures, potentially you can have leakage of the necrotic elements and gastric juice outside into the peritoneal cavity. So how do you ensure that it is closely adherent? And what do you do in the event that you don't have that communication or that adherence during your endoscopic drainage?
Okay, thank you po, sir. To answer your first question, the importance of the preoperative diagnostics or the preoperative CT scan is imperative. That's why I tackled on the timing of these types of the necrotizing pancreatitis. Because if it's less than 4 weeks, then it is the capsule is not yet mature. So the danger of having the yung leakage, kagaya po na sabi ninyo, is high. Although in one of the papers from Mayo Clinic, they were advising on doing an early transgastric drainage, especially for patients who has progressing or progressing organ failure. To answer your second question, sir, there is what we call lumen opposing stents. So these are small metal stents that are specifically created for these diseases. So as the name implies, it opposes two lumens. So it opposes the stomach and the cyst. But unfortunately, in our setting, lumen opposing stents are very expensive. It costs around 120,000.
Okay.
So in view of using these stents, yun na lang po. we use plastic stents na lang po with pigtails just to maintain the stents within the lumen and within the tract. So yun po.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Erasmo. So I think very interesting session in surgical endoscopy. Sir, there'll be one more guy training in endoscopic interventional endoscopic ultrasound, Dr. Chris Parilla. He'll be going to Hong Kong next year. He'll be going back to Cebu. So there'll be 3 persons, Luzon, Visayas, and Mindanao to be. So we can have centers now for training for surgical endoscopy in the 3 areas of the Philippines. So just an update. And then I think is the group ready for the live surgery from Dr. from Rizal Medical Center?